Hello friends, welcome to the live session of Pharmacology. Myself Dr. Mariya, Faculty of Pharmacology for Medico. Please click the link in your description box to download the workbook so that you can write the notes as we are discussing. Okay, so without much delay, let's get into the questions. We'll go to the first question. So first question is, variation in sensitivity of response to different doses of a drug in different individuals is obtained from. It's a very simple question. What are we looking at? The response to different doses of a drug. So we are plotting the response against the dose. So it is what is known as the dose response curve or DRC. Okay. So what are the different types of dose response curve? We have got a simple DRC and log DRC. Simple DRC is where we are plotting the dose against the response, whereas log DRC is we are plotting the logarithmic of the dose against the response. Why are we doing this? If we are doing a simple DRC, you're getting a rectangular hyperbola. For any comparison, mathematical comparison, they prefer a straight line rather than a curved line. So when you're converting it into the log dose, the middle portion, the 30 to 70% is a straight line where it is easy to compare between the drugs, as well as a wide variation in doses can be plotted when you're using a log DRC. What are the other benefits of log DRC? What are the uses of log DRC? You can measure the efficacy. What is meant by efficacy? The maximum response that a drug produces is what is known as the efficacy. So it is denoted by the height of the DRC. So if you have two drugs, okay, A and B, you can say both are having same efficacy. Okay. The second thing that we can get from this is potency. What is potency? The amount of drug that is required to produce a response. For example, if you want to take 50% of response, drug A requires this much dose, drug B requires this much dose to produce a response. So which one is more potent? The drug A is more potent because it is requiring the least amount to produce this response. So that is the second thing that we'll be getting. The third thing that we can get from this is the slope of DRC. What is meant by the slope? What does the slope indicates? If you have two drugs, for example, furosemide, the DRC is like this. Furosemide is a loop diuretic. Hydrochlorothiazide, the slope is like this. So if you see here, in this case, even a small increase in dose, you can see a wide variation in the response. Whereas here, over a wide range of doses, the response is remaining the same. So this you can, if drug B you can safely give in individuals even with wide inter-individual variations. Drug A is having narrow safety margin. So these are some of the things that we can infer from a DRC. So we can compare between competitive, non-competitive antagonism and all using DRC. Another thing that we can get is the therapeutic range. If you're plotting two graphs, one is a DRC for the therapeutic effect, another DRC for the adverse effect. The gap between the two will give you the therapeutic range. Next, go to the next question. A drug with high plasma protein binding has which of these properties? Less TFR, less drug interactions, higher volume of distribution, less tubular secretion. So just think, when you consume any drug, okay, for example, paracetamol, what will happen? It will first get absorbed through your mucous membrane. It gets bound with the plasma proteins, gets distributed in the body, reaches a site where it goes and acts. Finally, it goes to the liver, which is a primary site of metabolism. The function of liver is to convert whatever molecule, polar or non-polar, into polar so that it is water soluble and can be excreted through kidney. So where is this plasma protein binding happens? That is at the level of distribution. Okay. Which is active drug? Free drug or the bound drug? It's a free drug that is producing the actions. So if it is highly protein bound, the drug remains in the vascular compartment. So what happens to volume of distribution? What is meant by volume of distribution, or I would rather say apparent volume of distribution? If you consider the whole body as a single compartment, it is an amount in which the drug is uniformly distributed, is what is known as volume of distribution. So if it is highly protein bound, the drug will remain within the vascular compartment. It will not get distributed to the tissues. So it will have a low volume of distribution. So this option is wrong. If it is high plasma protein binding, it will have low volume of distribution. Now, if we give two drugs which are highly protein bound, for example, aspirin and warfarin. Aspirin is an NSAID, highly protein bound. Warfarin is an anticoagulant that is also highly protein bound. So, aspirin will displace the warfarin from its protein binding site and can lead to displacement reaction. So, there is more chance of drug-drug interactions when we are giving, when the drug is highly protein bound. So, this option is also wrong. It is not less. There is more drug-drug interactions when the drug is highly protein bound. Now, what happens to GFR or the glomerular filtration rate? It depends upon the filtration through the glomerular membrane, that in turn is dependent on your renal blood flow as well as protein binding. So, if it is highly protein bound, it will have difficulty in going through this fenestrated membrane. So, there will be less GFR. So, this is a correct option. Now, what about the fourth option? What is happening to tubular secretion? Tubular secretion is not dependent on your renal blood flow or your protein binding. Tubular secretion is mediated through transport proteins. We have organic acid transport proteins, organic basic transport proteins and all. So, it is not dependent on your protein binding property. Okay. Now, what about, so the answer here is less GFR is a correct answer. Now, the acidic drugs bind with albumin and the basic drugs bind with alpha-1 glycoprotein. Okay, so which are the acidic drugs? You have penicillin, warfarin, sulfonamides. Basic drugs like opioids, tricyclic antidepressants, amiodarone are examples of basic drugs. So remember the 4 Ds. One is duration of action. What happens if it is highly protein bound? Only the free drug is active. So it gets slowly dislodged from the bound site. The duration of action is prolonged. So duration is prolonged. Okay. There is more chance of displacement reactions we have discussed earlier. Okay. And then what about dialysis? Okay, dialysis, if it is highly protein bound, it will not be effective in dialysis. So, similarly, if it is having large volume of distribution also, if it has high tissue penetration and large volume of distribution also, it will not be a candidate for dialysis. So, these are some of the important things that you should know regarding protein binding. Now, next, go to the next question. Low apparent volume of distribution indicates. So, as I told earlier, what is apparent volume of distribution? If you consider the whole body as a single compartment, and if the drug is uniformly distributed, what is that amount that is required to uniformly distribute the drug to get the required plasma concentration? But often it is not that happens. We have tissues in between, we have membranes in between. So, it is not always uniformly distributed. So, low apparent volume of distribution means, whatever the first option, the drug is not extensively distributed in organs and tissues. That is a right answer. If the drug, as I said earlier, if the drug is highly protein bound, it will remain within the vascular compartment. If it is remaining within the vascular compartment, it will have low volume of distribution. If it has extensive tissue penetration, it will have large volume of distribution. Now, what are the factors determining volume of distribution? This is repeatedly asked. So, if you think and then you can answer, okay, if you get the concept right. So, if it is having polar, if it is having low lipid solubility, so our membranes are all lipid bilayer. So, if the drug is lipid soluble, it can easily cross the membranes. It will easily get distributed. So, what will happen to volume of distribution? It will be more. So, if it is polar, if it is having less lipid solubility, it will remain within the vascular compartment. Volume of distribution will be low. Okay, if it is highly protein bound also, it will remain within the vascular compartment. Again, the volume of distribution will be low. Large molecular size, again it will have difficulty in crossing, it will remain within the vascular compartment. Again, the volume of distribution is low. Fat content, that is, it is low in case of athletes. Okay, so high lipid soluble, excessive fluid conditions like renal failure, liver failure, where there is plasma protein amount is decreased because of hypoalbuminemia, and where the fat content is more in case of obesity, females or elderly, there is higher volume of distribution. Clear? Let's go to the next question. Loading dose of a drug depends upon all except clearance, volume of distribution, half-life, bioavailability. Okay, so what is meant by this loading dose? So usually the drug, we need to give an amount of drug to reach the steady state plasma concentration. So usually it will take around 4 to 5 t-half to reach the steady state plasma concentration. So if it is a drug with long t-half, it will take a long duration to reach the steady state plasma concentration. So what is this idea of loading dose or the two-dose strategy is, we are giving an initial loading dose to load or saturate the tissue stores so that the drug reaches the desired plasma concentration at a faster rate. Okay, so we are basically giving this dose to load the tissue stores. So the main primary factor that determines the loading dose is your volume of distribution. Okay, whereas the dose that we are giving to maintain the plasma concentration is what is known as a maintenance dose. The main factor which determines the maintenance dose is your clearance. Right? So clearance is a main factor which determines your maintenance dose, whereas the loading dose is mainly dependent upon your volume of distribution. Also bioavailability. Bioavailability is a fraction of drug that is available in the systemic circulation, and half-life also determines your loading dose. We give loading dose for drugs with long half-life. So the question here was loading dose depends upon all except. Okay, so the except answer is clearance. It is dependent on your volume of distribution, half-life as well as bioavailability. Okay, so this is a formula. Cp is the target plasma concentration that you want, volume of distribution, and F is your bioavailability. Okay, so the main determinant of loading dose is your volume of distribution. The main determinant of your maintenance dose is your clearance. So for clearance, it is the same formula. Instead of volume of distribution, we'll put clearance. Okay, so this is what we are doing. We are giving an initial high dose to reach the effective concentration in a short span of time. Now let's go to the next question. Diamox is given for glaucoma. What is Diamox? It's a non-competitive antagonist of carbonic anhydrase. The effect is, so what we are seeing here is a enzyme inhibition. What type of enzyme inhibition is happening? It's a non-competitive antagonist or non-competitive enzyme inhibition. So the question here is, what happens in non-competitive enzyme inhibition? So I hope you're familiar with these terms. Km, Vmax. So what is meant by the Km or the Michaelis-Menten constant? It is an amount of drug that is required to produce half maximal velocity. So what is Vmax? It's a maximal reaction velocity. So the concentration of drug that is required to attain half maximal velocity is what is known as the Km. Okay, so this is almost enzyme inhibition is similar to that of your competitive, non-competitive and receptor antagonism. It is almost the same. So what happens in case of competitive antagonism? Okay, we'll come to the answer after discussing about competitive and non-competitive antagonism. In competitive antagonism, as you all know, there is a competition between the the substrate and the drug for the active site. So if this is a substrate, the competitive antagonism binds to the same active site of the enzyme. Okay, there is a competition. Okay, examples of competitive antagonism is, as you all know, physostigmine, which is an anticholinesterase, competes with acetylcholine for the cholinesterase enzyme. Another example is atorvastatin, inhibiting HMG-CoA reductase enzyme, which is a major rate-limiting enzyme for cholesterol synthesis. So you can see here, this is a substrate. In competitive inhibitor, it is binding to the same active site. So when you are drawing a graph, what will happen? Vmax is the maximum velocity, reaction velocity. So when you're giving a competitive antagonist, you can see that it still reaches the maximum velocity provided you increase the dose of substrate. So if you increase the dose of the substrate, you can reverse the inhibition. That is why competitive inhibition is otherwise known as surmountable inhibition. Okay, so what happens? The Vmax is not changed. Vmax is not changed, but what happens to the Km? So previously, if half maximal velocity was reached here, now the half maximal velocity is reached at this concentration. So in competitive antagonism, the Km is increased, but Vmax is remaining the same. So the reason being, it is binding to the enzyme, but not changing the enzyme structure. Okay, so if you increase the concentration of substrate, this inhibition is reversible, it is surmountable. So same maximal velocity is obtained, but you require a more dose to produce that same effect. So here the Km is increased, but Vmax is remaining the same. What about non-competitive inhibition? In non-competitive inhibition, the drug binds to a different site, not the active site of the enzyme. The different site is what is known as the allosteric site. You can see here, it comes and binds to a allosteric site. And what does it do? It alters the enzyme structure. Okay, so however much substrate you increase, since some of the enzyme structure is altered, it is not effective. So however much you increase the substrate dose, you won't get that maximum reaction velocity. So in case of non-competitive inhibition, however much you increase a substrate, there is slight decrease in the Vmax, but the Km is remaining the same, because whatever enzyme is there, the drug can bind with the enzyme structure is not the amount of enzymes in which structure is not altered, the drug will bind with the same affinity. So Km is not altered, but Vmax is decreased because some of the enzymes have lost their enzyme activity completely. So however much you increase the substrate, you won't get the maximum reaction velocity. This is same as that of efficacy in case of non-competitive receptor antagonism. In non-competitive receptor antagonism, you can see the DRC, there will be flattening of DRC. Whereas in competitive receptor antagonism, you can see there is shift of DRC to the right, but the maximum response is still obtained. This is the same picture. Here, instead of here, we call it as Vmax, and the amount we call it as Km. Okay, so if you go back to the previous question, now can you tell me what is the answer? Diamox is a non-competitive antagonism. So in non-competitive, what will happen? Km is remaining the same, Vmax is decreasing. Okay, so you can see there is decrease in Vmax is the correct answer. Decrease in Km is happening in competitive inhibition. Okay, now let's go to the next question. Which of the following is true about the therapeutic index of the drug? So what is meant by the therapeutic index? Therapeutic index is the safety. It indicates the safety of the drug. So it is mainly therapeutic index we can calculate only in animal studies. Okay, there is something known as the lethal dose 50. What is meant by the lethal dose 50? It is a dose which kills 50% of population. That is why I said we can do this only in animals. We cannot kill 50% of human beings, right? So lethal dose 50 is the dose which kills 50% of animals. And what is ED50? It is the dose which is effective for 50% of animals. This kind of response we get only in quantile DRC. If it is an all or none response only, we will get how many number of individuals showed response. Okay, so the ratio between the LD50 and ED50 is what is known as therapeutic index. So if LD50 is large and ED50 is short, what will happen? It will definitely be more than 1. LD50 more means you need a higher dose to kill 50%. So, and ED50 small means even with a less dose, it is effective. So, if it is more than 1, it means it is a safe drug. If the therapeutic index is less than 1, it means it is having narrow safety margin. Clear? So, it is basically an indication of the safety of the drug. It's a ratio between the LD50 or the lethal dose 50 by effective dose 50. Okay, so ratio of median lethal dose in 50% of population to median effective dose in 50% of population. Okay. The next question that is related to your therapeutic index. A patient suffering from infective endocarditis was given a high dose of penicillin and gentamicin. Okay. Which of the following statements is correct regarding these drugs? Therapeutic drug monitoring should be done for both drugs as these have narrow therapeutic index. Therapeutic drug monitoring should be done for penicillin as it can cause severe anaphylaxis. Therapeutic drug monitoring should be done for gentamicin as it has narrow therapeutic index. Therapeutic drug monitoring is not required for any drug as both have wide therapeutic index. So there are two terms here. One is therapeutic drug monitoring or otherwise known as TDM. Other one is a therapeutic index. Okay, so usually this is something that is a misnomer. Therapeutic drug monitoring, when you hear the term, you will think, okay, it is something to do with adverse drug reaction monitoring, but it is actually a misnomer. Therapeutic drug monitoring is nothing but you're measuring the plasma concentration and seeing whether the drug is within the therapeutic range. Okay. If it is not in the therapeutic range, we'll adjust the dose so that it will we'll get the optimal dose. Okay, and the drug remains within the therapeutic range. So, it is not to measure for ADA. So this option is gone. Okay. Now next question comes: when should you do therapeutic drug monitoring? Okay, should we do it for antihypertensives? This is simple to talk that it is just the plasma concentration of the drug is monitored to look whether it is within the therapeutic range, but the process is very tedious process. Okay, so if we have good clinical markers, like in case of antihypertensives, you can just measure the BP to see whether the drug is effective, or in case of anti-diabetic agents, you can just look at the blood sugar values to see whether metformin or your glimepiride is working. Or in case of warfarin, we have got INR, which is a good test to correlate the action of warfarin. So if you have good clinical markers, you need not do a therapeutic drug monitoring. Or if the drug is having a wide therapeutic range, it's a safe drug, you need not take all the botheration to do a therapeutic drug monitoring. So in which cases do we do a therapeutic drug monitoring? Basically for drugs with narrow safety margin, or if you have wide inter-individual variation, or if you have to check for complaints, especially in case of psychiatric medications or certain antimicrobial conditions, or when you're giving a drug for prophylactic purpose like cyclosporin, it is an immunosuppressant. So if we have to make sure there is no other clinical marker, if the drug is not within the therapeutic range, the patient can go in for organ failure, which is not an acceptable effect. So these are some of the areas where we do therapeutic drug monitoring. So in this case, penicillin and gentamicin. Penicillin is a beta-lactam antibiotic. Gentamicin is an aminoglycoside. Which of these is having a narrow safety margin? Penicillin is having a wide therapeutic range. It is a safe drug. Gentamicin is an aminoglycoside that is having a narrow therapeutic index or narrow safety margin. So here the answer is therapeutic drug monitoring should be done for gentamicin as it is having narrow therapeutic index. Is that clear? Okay, so this we have already covered. It's a plasma drug concentration to optimize the drug therapy. Which are the situations where we use this? Drugs with narrow safety margin like lithium, digoxin, aminoglycosides. If the inter-individual variations are high like antidepressants, when you're giving aminoglycosides, especially in renal failure, since they can cause nephrotoxicity, we don't have any reason for failure of a particular regimen. We may try to see whether adequate plasma concentration has been obtained. To check for patient compliance or adherence in case of psychiatric medications. When we use it for prophylaxis, and in case of poisoning also for prognosis, we may check the plasma concentration. Which are the situations where it is not useful? As I've said earlier, if you have good clinical markers, you need not test the plasma concentration. If the drug is activated in the body or it causes irreversible inhibition, there is no point in checking the plasma concentration of levodopa when levodopa is actually converted into dopamine. So only if there is a good correlation between the plasma concentration and the drug action. Okay, so the plasma concentration and drug action should be correlated. Then only there is utility of doing a therapeutic drug monitoring. Okay, and drugs with wide therapeutic range also, there is no use of doing a TDM. How do we do this TDM? We use HPLC machine as one method by which you can assess the plasma concentration. You can use spectrophotometry also, which is another technique that we use for doing the TDM. Okay. Okay, now we come to the next question. Which of the following act through G protein coupled receptor? This is again important topic, but it's a recall based question. G protein coupled receptor. You have 4 important types of receptors in our body, right? The most important and most common receptor is your G protein coupled receptors. Then you have inotropic receptors, which are ligand gated receptors. You have a ion channel in between. That is what is inotropic. G protein is linked with the G protein. Okay, and it brings about the action subsequently. Enzyme linked receptors, they have got an extracellular and an intracellular component. Once the drug binds to the extracellular, the intracellular enzyme, usually it's a tyrosine kinase, gets activated, that phosphorylates and brings about the action. Then you have nuclear receptors. Nuclear receptors are receptors that usually you have cytoplasmic as well as intranuclear receptors. So what they do is they bind and the receptor complex will shift to the nucleus and bring about changes in transcription. That is how it brings the action. So among the 4, the fastest is inotropic or the ligand gated ones, and the slowest is your nuclear receptors. Okay. Now what about this question? Among this, which is a G protein coupled receptor? It is your acetylcholine muscarinic receptors. Okay, we'll come what are the different types of G protein. Insulin receptor is an enzyme linked receptor. What are the other enzyme linked? You can remember prolactin, insulin, growth hormone. These are 3 important drugs that acts via enzyme linked receptors. Nicotinic receptors as well as GABA A receptors are ligand gated receptors or inotropic receptors. Okay, so among this, the G protein is your acetylcholine muscarinic receptor. So what is basically this G protein? G protein, they are otherwise known as heptahelical or serpentine because of the shape. They have 7 transmembrane chains in them. So they're called heptahelical or serpentine, or another name is metabotropic receptors. So when the ligand binds here, initially there is G protein consists of GDP that is bound to alpha, beta, gamma subunit. So when activation happens, the alpha and the GDP component is the GDP gets released, GTP gets added. There is separation of this alpha subunit from the beta gamma subunit, and what will happen? It will go and stimulate the various effector proteins that bring about the action. So we have different subtypes of G protein. GS, GI are the common ones. GS means it stimulates the adenyl cyclase. GI means it inhibits the adenyl cyclase. So by increasing or inhibiting adenyl cyclase, it increases or decreases cyclic AMP and thereby brings about changes in the protein kinase. So GS example is beta receptor, GI example is alpha 2 receptor. GQ is activating the phospholipase C, and which in turn gets converted into PIP2 is converted into IP3DAG. GI2 I3 is by coupling with small GTP binding proteins or known as Rho proteins. GO is what is we saw now, the muscarinic acetylcholine receptors that act by directly inhibiting the ion channel. So they the G protein coupled, either they activate through adenyl cyclase or IP3DAG pathway, or they directly go and opens the small ion channels like calcium and bring about their action.